And are you involved in the Bruce Keogh review of 24/7 care?
I'm not directly on the group, but it's coming from the medical directorate. So the answer by default is we will, have input to it, and therefore will be. This is something which Bruce has spoken about for many years now, and I would support him wholeheartedly. We need better care for our patients, 7 days a week. That doesn't mean doing the same thing on every day, but it will mean, I think, looking at how GPs work as well as hospitals work.
So would you like to see practices open longer, perhaps into weekends?
Well, I miss Saturday and Sunday working, and I think the new contract, in a way, did us a disservice, partly by restricting in the contract what people do. So there's a great reluctance to move beyond the contract now. But also, I think the way out of hours was handed over to PCTs was done very badly in many areas. It disincentivized people from working in cooperatives. We had a fantastic co-op in Birmingham called Badger, run by Faye Wilson. It was exemplary. And then the PCTs come in, mess with their contracts, reduce the value, and we end up with an inferior service. I led the ministerial review of the Urbani case in Cambridge. I saw how bad things can go, and that wasn't just a single doctor, it was how the PCT was run and managed those contracts as well. And I saw the wonderful work in Greenwich and Bexley and elsewhere around the country. And so I think we can do better.
And what would you like to see change from where we are now? Would you like to see co-ops return?
I think co-ops should be incentivised so that local GPs regain the ownership. But I also think we should be working much more closely with nursing and specialist colleagues. So I think we've moved on from where we were. And some of the work in the localities could be done much better working with nursing colleagues.
And when you say incentivise, presumably you mean a financial incentive?
Well, I think one of the issues we've got is the contract itself. Perhaps has run its course, and we probably need to work now looking at how care is provided in a slightly different way for out of hours. It would be different in a very rural area to in a city, the model of how you provide that care. But the way it's moved, I think there needs to be a review, and we need to involve the BMA in that as well. But it's more as well about how we work with emergency departments. What is an emergency department, an A&E, how GPs have got a particular role in particular localities. It might also involve how you use community hospitals. I mean, the world is very different now to it was 5 years ago. Now, if you've got a heart attack, you 999 straight into the heart unit. If you've got a stroke in the majority of the country, you go to a stroke centre. People are living now, whereas when I qualified in 1982, I became a GP in 1986, I can remember visiting a farm outside Droitwich and having to, I had a big brick of a mobile phone, a carrying handle mobile phone, and I guided the ambulance in to the person who'd had a heart attack with my sort of mobile phone, immobile phone. Now GPs don't go out for chest pain. The world has moved on. So I think we've got to think about, well, what does urgent care, what does out of hours care look like? How does it work with the 111 system? But how do you get local GP ownership? So I don't think it's going back to where we were. It's thinking about what needs to be provided now at the start of the 21st century.
So you're not ruling out financial incentives for GPs to get more involved with co-ops?
I think we need to use incentives in a way to improve the quality and safety of care. I wouldn't rule anything in or anything out.
Okay.
But just like how we would use tariff to look at the year of care model, or how you would incentivise care in various different ways for long-term conditions, then I think we should have a radical look at that.
And presumably you also think that GPs should be more active in managing patients in the community, so emergency admissions reduce?
Well, I don't think we should just be looking at GPs. I think really we should be looking at the primary care team. And in some areas it works very well as a team. And that team involves the patients. It involves the ambulance trusts. It involves nurses, community nurses, as well as GPs. And it might well include more outreach from hospitals for people with COPD using telehealth interventions. So what we've got to try and do is get to the point where we try and prevent people having to call for an emergency in the first place by being more proactive, and then putting clearer pathways in for patients, particularly those who might panic with COPD or other illnesses, which might be able to be given advice or monitored in different ways. So I think the whole thing about 7-day working is not just about hospitals, it's about primary care. And primary care, we would say, we need better access to diagnostics as well.
Yeah.
And we need better continuity of care for our practice list.
And do you think the quality premium opens GPs to criticism that they're rationing services for their own personal gain?
I think how it's been sold certainly does, but I think if we can work with the profession, with the quality premium, I think there are ways of incentivising behaviours. But we also need to learn from QOF, which I think, to be perfectly honest, has now become such a tick box system that it disincentivises holistic care in many cases.
Yeah.
But it also has perverse incentives in that, or disincentives in that the thresholds also mean that some practices might not push harder for the more vulnerable, harder to reach groups. So I think we need to have an adult conversation about how we use incentives, how we work across geographical areas with federations of practices, how we look at how the community teams trained and grow. I think there's a great opportunity there.